felt a sense of shame. And I know that sounds silly, but I was like, no one wants to hear about this. They don't, they don't want to talk about like feeling dry in the vagina or less sensation, difficulty with orgasm, just my skin like no one wanted to talk about that. I didn't want to talk about it. I felt alone, and my doctors didn't bring it up and didn't really recognize the long-term implications to my, as you speak about, my health span.
Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody. It's Dr. Vonda Wright, and welcome back to Hot for Your Health, where I talk to innovators, clinicians, remarkable people. And I'm so happy to be joined today by Dr. Corinne Menn. She is a board-certified obstetrician gynecologist. She is one of the founding and leading doctors at MyAlloy. She's long had a telehealth platform of her own where she's treating women in midlife. You are a thought leader and an expert on some of the most critical parts of the menopause conversation and so many things. So we were just talking offline about what things women have heard and what things women haven't heard. And you are always open to share with the community at large and where you speak about your own journey and health in breast cancer and now as an expert serving that population. But I think our conversation, Corinne, needs to include what you suggested, which is the other things that make women feel left out in the midlife and menopause conversation. And so things like, we can get into all these things. I think they're so critical, and I'm going to learn so much. Things like endometriosis, previvors, women with PCOS and what they do on their menopause journey. The fact that even for women with no true contraindications, still only 4 to 5% of all women choose to optimize their hormones, and where does that leave them? So what are the things in this basket that you hear women saying most often that we need to answer their questions?
Well, I mean, I think the biggest thing is we all see the menopause movement, the moment, the train is no one's stopping it, right? And that's great. And there's a grassroots groundswell, I think, of patients rising up, women, we see it at conferences and at speaking events, and we see it on social media, and the doctors who are interested in all of that. But and I think that is great. And it generally speaks to kind of the average, quote unquote, woman in the midlife transition. And we know that for the vast majority of these women, the benefits far outweigh the risks of menopausal hormone therapy, and that they should at least have that as an option. It's not that everyone has to use it, right? But there are thousands, millions of women really around the world who feel left out of that conversation. They don't truly feel part of it. Yes, they can exercise and they can eat right, but they feel like, well, but maybe hormones aren't for me, or I've been told they're not for me, wrongly often, right? Because there's a lack of provider education out there. And so I think there is a huge contingent left out. And everyone looks to me because I'm a breast cancer survivor, and I talk to the breast cancer community about what options they have, whether it's for local vaginal hormones or how do they manage things non-hormonally, or if they deserve, which they do, a conversation individually about their breast cancer case. And if they've recovered and they're in survivorship phase, are there some of these breast cancer survivors who might consider menopausal hormone therapy? Mm-hmm. And so I speak about that a lot, but I always want to make sure we're bringing along these other left out vulnerable women, and like some of the, categories you spoke about, previvors, right? So cancer previvors. And that term is a little funny, but basically it's women who identify that they have a mutation to some hereditary cancer syndrome. And it's not just BRCA anymore, right? So as we elevate education about these hereditary cancer syndromes, more and more primary care doctors are testing patients. So more and more women are finding out they might have the CHEK2 mutation, or they might have Lynch syndrome. And POB mutation, and there's a whole host of them. And so they may have an increased risk of ovarian cancer. And many of these women, including the BRCA carriers, have ovaries out prematurely, but they don't have cancer yet. So they are plunged into surgical menopause to do something preventatively, and then no one manages what's next. So that's another big group. So it's not just cancer survivors, it's that. And then anybody else who is facing earlier menopause. And the one that we were talking about offline is the endometriosis community out there is vast, huge, and equally as misunderstood, dismissed in terms of their premature menopause, issues.
Well, let's start with one population that is either, and I realize they're probably not one population, but very young women, youngish women in their 30s who either have premature ovarian failure or due to some reason have early surgical menopause. Let's talk about the kinds of searching those women need to do, the questions they need to ask, where they can find, because you can't just sign up for surgery. You need to have in the OR what needs to happen. Do you come out with a patch on your belly? Walk us through the steps that women in that kind of category need to think about.
Yeah. And so we all, as a surgeon, you do pre-op counseling, and part of pre-op counseling for any surgery is, what to expect before surgery, during surgery, immediate recovery, and the long-term recovery, and what's that going to look like. And so it's really astounding that when we're talking about women's ovaries being removed prematurely, so we're talking about under the age of 40, and then certainly under the age of 45, which is considered early menopause, prior to 40 is premature menopause. Recent studies have shown that less than half of those women, more like only 30%, actually get a plan of action and are appropriately being given back their hormones, which is considered the standard of care, right? The standard of care is full HRT, not MHT, hormone replacement therapy, meaning we're replacing what you would actually truly be making at that age because you're young, up to at least the natural age of menopause, and then you could shift to lower menopausal hormone therapy doses. So what should they be asking? They should be asking before they enter the OR, what is your plan for the severe surgical abrupt estrogen deprivation that you're about to cause me? And I have to tell you, sadly, many times the answer is, well, we'll see how you do. Well, we'll see at your post-op visit because, we don't want to raise the risk of blood clots, and we can talk about why that's an erroneous way to think about it. And I always, in a kind of a crass way, maybe I often say, I could imagine if there were all of these young men, late 20s, early 30s, mid 30s, that we were proactively to treat other things, not because of cancer, not because they had a contraindication to testosterone, and we were surgically removing their testes and removing all source of sex steroids from them. Do you think we'd send them home and tell them, come back in a few months to see how it feels, see how it goes? No. But that's what we do to these women. And the suffering is astounding out there. And I'm talking from major cancer centers. Major surgical centers, I should say. And it's immediate.
Immediate suffering. It's like falling off a cliff.
Falling off a cliff. And, I always speak from experience because I myself experienced premature surgical menopause. My previous two temporary premature menopause were due to cancer treatment. So for early stage breast cancer. So it was from chemotherapy. So it was temporary and it didn't happen abruptly. Like it happened over a period of a few months as the chemotherapy kind of continued to shut down my ovaries. But then I was young enough, my ovaries popped back and, I felt a little bit better, right? And then again, temporarily, we chose to with medication, but then I elected to pause that because it was really tough on me and to kind of take my tamoxifen without that ovarian suppression. So I had some control, it wasn't abrupt. And so I wasn't even thinking about it when I made the decision electively to say, you know what, my mom died of ovarian cancer. At the time I had tested negative for the BRCA gene, and we can circle back to that. But I was like, well, my mom died of ovarian cancer. I had a breast at 28. I'm going to just have my ovaries taken out while I'm going in for a breast reconstruction, redo. I was honestly, it sounds so dumb and naive as an OBGYN, but I literally, it was like I was hit by a truck. Like overnight, my menopause symptoms were horrible, worse than they were previously. And over, I'd say 2 months, I easily gained 10 or 12 pounds. And I started to, as we know, the kind of like a metabolic syndrome type of, picture was confronting me with, more belly fat, cholesterol being raised, just not feeling great, gaining weight, all of these things. And at the time, even then, I think I kind of was like, oh, I'm not exercising. I didn't even really put two and two together how profound that loss of ovarian hormones are and why this gets back to kind of provider education. So I think this is why women aren't given the full picture of what it means to have abrupt surgical menopause, because it's more than just hot flashes, right? So it's kind of like the sentiment out there is like, well, you've got good bone health, have some vitamin D, just we'll see how those hot flashes go. No one's thinking that, as soon as those ovaries are taken, it's an abrupt loss of, you start to lose bone. We know an acceleration of lean muscle mass, all the metabolic things you talk about, sexual dysfunction, mental health, sleep issues. And no one even talks to these women that we've got extremely clear data based on decades of studies that premature menopause puts women at very high risk of all-cause mortality, cardiovascular disease, as well as these other things. And so that's why the standard of care is full replacement surgery or hormone replacement therapy, unless there's a contraindication. But many of these surgeons and doctors who are taking care of these patients think that hormone therapy is a contraindication in some of these populations, whether it's because of endometriosis or because they carry hereditary cancer mutation. And so they're kind of counseled, well, yes, those are risks, but if you can avoid hormones because hormones are so dangerous, like that's the attitude. And it's just wrong. So they're actually hurting the women more than they're helping them in many ways.
Do you think this knowledge deficit, is it a knowledge deficit? Is it a care deficit? Is it, by and large, most surgeons are still men and never will have ovaries? What is the big disconnect?
Well, I mean, I can tell you as an OBGYN, no one ever sat us down and said, listen, when you've got a young woman and you're taking out her ovaries, you have to think about all of these things, right? Honestly, I was never taught that. I never actually was taught how to write a hormone replacement therapy prescription. We never wrote it because it was 2002. The WHO had just come out. And so I really think, I don't think listen, I always say the majority of doctors don't go into medicine to take care of women and to be an asshole to them, right? They're not trying to be a jerk, right? But, there's a lot of dogma and it's a lot of, if you weren't trained that way, it's kind of not what you do. And then a lot of the surgeons who are doing ovarian surgery these days, it's become a subspecialty. They send these patients back to their regular OBGYN who also was not trained. So the GYN oncologist is like, all right, I took your ovaries out. I don't want to manage this. Send it to the general OBGYN who doesn't have any menopause training. And then there's also a lot of, because we don't have general education about basic menopause hormone therapy, when you add in anything that's complicated, like endometriosis or a higher risk of breast cancer, or, maybe a clotting disorder in the family or some other thing, there's just an immediate knee-jerk reaction like, well, we'd rather stick with non-hormonal things. And we're really losing the boat.
You know what, Corinne, I have, people don't primarily come to me for people who have gone into early menopause for whatever reason. They don't primarily come to me for that kind of care, but I get lots of women who come to me for the kind of care I give, musculoskeletal, who have gone through this. And when I start, because I treat people as a whole person and I ask them about their midlife journey, about their hormones, 20 years later, they still have not been treated, and they are older than their chronologic age, their biologic age, down to very superficial things like their appearance or how their joints work or the pain that they're in from a musculoskeletal system standpoint is biologically much higher than their chronologic age. They might be 45 or 50 years old, but because they've had this deficit for 20 years, they're old women.
They are. And I felt that way. It was from a psychological standpoint. I remember feeling that my friends and my peers, they were like in their early 30s. They looked great. They were kind of out of their silly 20s where maybe they were partying too much and not taking care of themselves. And all the 30-year-olds were really into like, they were adults. So they were thinking a little bit smart about their bodies and they looked great. And maybe their sex lives were better because, they were in these stable relationships now. Like and I remember feeling, and they looked great. And I just remember feeling like, oh, well, just wait. I'm like, you'll have a menopause belly soon. Because I was never heavy, but I was always a very, very, very skinny person, just like naturally my frame. And again, so I understand why everything is relative. Like for me, all of a sudden having like rolls in my belly and just feeling just not myself, my skin changed underneath, my eyes hollowed out, my bone, I started to get, very close to osteoporosis, all of these things, lots of sex life issues, right? All of these things. And I felt shameful. It didn't feel comfortable saying menopause or all of these things in polite company, so to speak, because remember, there was no Instagram accounts about menopause. That was not the thing when I was 32 years old, right?
Yeah.
No one talked about this.
Instagram didn't come around till 2011. So
I will tell you, I felt, and I don't know why, but I honestly felt a sense of shame. And I know that sounds silly, but I was like, no one wants to hear about this. They don't, they don't want to talk about like feeling dry in the vagina or less sensation, difficulty with orgasm, just my skin like no one wanted to talk about that. I didn't want to talk about it. I felt alone and my doctors didn't bring it up and didn't really recognize the long-term implications to my, as you speak about, my health span.
Yes.
Not just my lifespan. They just felt happy that my breast cancer seemed to be in remission and, no signs of disease. And as long as that was okay and my blood pressure was normal, then you're good to go. Like that was basically it.
Life saved, but quality of life not saved.
And I didn't really know what to ask for because I will be honest, I was not a menopause expert then. I was not, and that's what led me to get educated. But if it wasn't for that experience, I don't think I would have found myself in this world. It was only because I was like, damn, I don't know how to take care of myself, much less my patients with endometriosis or other reasons for benign early menopause, non-cancer menopause.
We had talked earlier about endometriosis specifically. And so there is the thought that if you have your ovaries out to control the growth of that endometrial tissue, so it's not only estrogen replacement that you're eligible for once you eradicate the endometriosis, but you were saying that we still need to be able to control the growth of what was uterine lining escaping, right? Because that's what endometriosis is, right? Explain.
So, the treatment of endometriosis, treatment-induced menopause is another area where it's not really, women are not really getting great care. Now, so endometriosis is treated a lot of different ways. Some of these women are controlled with like continuous birth control pills. Others are controlled with, medications that actually shut down their ovaries. And when we do that, we actually give them something called add-back therapy. We add back a little bit of estrogen and a synthetic progestin so that they don't lose bone and have, ill effects on cardiac health and such. But for some women who have very severe endometriosis, at some point in time, they choose to have a hysterectomy. And we'll talk about hysterectomy alone. Uterus out. But sometimes they also need to take the ovaries. They try to, preserve the ovaries when they can, but sometimes the ovaries come out because endometriosis can involve the ovaries. So endometriosis is basically the lining of your uterus those cells can be abnormally implanted on the outside of the uterus or on the tubes or on your ovaries or on your pelvic sidewall, on your bladder. So if you've got very serious endometriosis, sometimes this kind of really more, like a complete hysterectomy with your ovaries is the solution. And these women now go through abrupt menopause. At first, they're often happy because finally they are without pelvic pain, which they had suffered with for a very long time. And so I think it's understandable and reasonable that doctors and women fear adding back that estrogen. But we have something called data, right? There are papers on this. There's studies, and they've looked at this, and that it appears that giving back menopausal hormone therapy or HRT in low doses, so estrogen alone, and does not appear to increase the risk of endometriosis coming back. But what the general guidelines, and the British Menopause Society actually has a beautiful new statement on this, and anybody can Google it. So it's British Menopause Society Managing Menopause After Endometriosis. And it's really practical. And I often talk to patients about printing that out and bringing it to your surgeon beforehand. And it does suggest, if the surgeon goes in and sees that there was a lot of endometriosis implants, you might consider also adding progesterone. So it's just the same idea as when a woman has her uterus. We give her estrogen, we give her progesterone to keep that uterine lining from getting too thickened. So these women should also, because I have had patients who we did start on estrogen alone, and after a few months, they'll tell me that they feel, some pelvic pain or discomfort, and we add back the progesterone, and that's helpful. But these women often don't have a pre-op plan. And so it's all about being prepared, right? Prevention is the name of the game, right? And so you should have a plan, a hormone plan. And some surgeons are reluctant to have women wake up with their hormone therapy started, but that's exactly what they should do. They can wake up in the recovery room with a transdermal FDA-approved estradiol patch, or gel, or spray. That's typically the preferred transdermal estradiol, although some of these women can also use an oral estrogen. But immediately post-op, transdermal estrogens do not raise clotting factors. It's very safe. And to this day, I have surgeons for lots of different surgeries tell me, oh, well, we'll restart the estrogen after 6 weeks. I'm like, okay, so you're going to take her from a normal physiologic estrogen range. You're going to starve her of estrogen, which we know has metabolic problems associated with that. And then you're going to restart it. And you wonder why maybe post-op recovery doesn't go as well. Even from a wound healing and inflammatory standpoint, there's so many benefits of just continuing that steady amount of estrogen in a transdermal way. So I tell them that they should wake up with that patch on them.
Absolutely. So what you've said is so many things, but if you do one thing, people listening, you're about to have surgery of any kind.
Yes.
Within your reproductive organs.
Yes.
Start asking the questions, do I need hormone replacement? And if I don't, why not? If you're a young woman, a youngish woman, right? If you're not already postmenopausal, but way before that, don't stop at someone saying, no, please, let's ask more questions. Yes, but not now. Let's ask more questions. Yes, but I don't do it. I'll give you to somebody else. Well, that's a legitimate answer, but who is that somebody else? And I need to see them pre-op. I don't need to do this my pre-op. Right.
Yeah, totally.
It's a whole woman plan is what you're outlining.
Yeah. And if your situation, because there's lots of different medical situations out there, means that you actually shouldn't be giving back estrogen. So maybe you have a hormone sensitive cancer, whether it's ovarian, endometrial, breast, and actually there's updated guidelines for the Society of Gynecologic Oncologists, SGO, recently came out that really reviews that for really the most GYN cancers, actually these women can have hormone therapy back. So there's a few subsets that we kind of are a little bit more cautious, but if for some reason you really cannot use systemic estrogen, they still need a plan for you. And the plan cannot be, let's see how it goes, because that is often the plan when hormones are contraindicated, which is rare, but when they are, we need to have a plan. And the thing is, we do have ways to help these women. For instance, if they can't use estrogen, we know what is going to happen. You talk about bone all the time. You are going to have rapid bone loss. If we know that we're not replacing your estrogen, maybe you have advanced estrogen receptor positive breast cancer and you're going to be going on, long-term treatment for that. Whatever the case may be, there are proactive bone-specific medications as well as an aggressive and planned and supported exercise and nutrition program that can go into place so that they don't see you 20 years down the road at 60 or 55 with a broken hip, right? And you see those people, right? But that kind of holistic plan doesn't happen unless you're a really squeaky wheel. So there are people out there who can help you, but you have to be your own best advocate, because I'm telling you,
right.
No one's coming to save you in premature menopause because they're not educated in regular menopause. So you have to really be responsible for making sure you're getting that care that you need.
Yeah. You have to ask the questions till you get good answers, and maybe it'll take a few investigations. But we've talked about estrogen, we've talked about progesterone. Is there any role for, and this may be showing my lack of science in this area, but is there any role, or let's talk about two things first, because it's hot off the presses, the new guidelines for vaginal estrogen and gynecourinary syndrome of menopause. There is no contraindication for vaginal estrogen in any of these cases we've talked about.
All of these different scenarios, whether it's cancer pre-vivors with hereditary risks for cancer, whether it's endometriosis, history of fibroids, a clotting disorder. I don't care if you just had a massive stroke. Oh, I care about that. But in terms of vaginal estrogen, So people ask, should I wait for the vaginal estrogen and see if I get symptoms? I said, no, it's do you wait to take your vitamin D until you have a bone fracture? No, shore things up, keep it healthy, because we know it's chronic and it's progressive genitourinary syndrome of menopause. So we know you're having an abrupt withdrawal of hormones, whether you're taking systemic hormone therapy or not, just plan that should be part of your plan, and you don't need permission from anybody to do that. It's safe for everybody. So yes, that's important. And then the other hormone that we don't talk enough about for women, and I don't think this should be controversial, but unfortunately we don't have super clear guidelines on this, is testosterone, because these women, they are losing a major source of androgen production. The ovaries are not the only place that makes testosterone, right? There's conversion in fat cells, adrenal glands, there's other places in the body, but a large source is coming from these ovaries. And we do have science that tells us that surgical menopause lowers average testosterone by about 50%. But honestly, nobody talks to these women about that. And if they bring it up, they're like, well, let's see. Well, all right, we'll start with estrogen and, we'll see, maybe we'll add that. And I probably had that approach for years, but because of the bigger conversation and people like Kelly Kasperson and Rachel Rubin and other doctors out there talking about this importance that testosterone is a female hormone, I think this is another piece of the puzzle that these women with early menopause need to ask. And it's even harder for them to get answers on that because it's not as clear. But to me, this is kind of like Captain Obvious. Like we're like literally remove. It would be like if we removed like 3/4 of your thyroid and just as well, that one little left over, that'll do enough. Well, it's the same with testosterone. And so, I check these women's levels sometimes with it, and it's like mine was like 4, right? Like it was so low, And these are young women. They're in their 30s, right? Some of them are even younger. I've seen 27, 28-year-olds who come to me who it's been 10 or 12 years and no one's done anything for them. And they're like, oh, I thought I couldn't have it,
Yeah. Well, and just to clear up anybody who hasn't heard yet, testosterone is not a man's hormone. It is a hormone. We have a lot of it. And here's how you can get it. It's FDA approved for low libido in women. You rip out your ovaries, it's going to change your libido. So even if that is the only thing your clinician will respond to, it's probably the case. And so, for not even besides all the other reasons that I personally love testosterone and love it for my patients,
Yes.
That is the one that's FDA approved that nearly.
Well, it's not FDA approved, it's a consensus guideline. We don't have an
Oh.
FDA approved version of it for women, but we have expert consensus. It's the global position statement on the proper off-label use of testosterone. And the thing is, because nobody talks to women about it, what happens is they wind up having low libido and they hear through the grapevine that, oh, they can get testosterone, and then they get funneled to a pellet factory, and they don't necessarily need that testosterone via pellets. They can get it very safely in a way that's very easy to control with a low dose transdermal testosterone gel. Even so, we can use an FDA approved testosterone gel, or sometimes this is a case where you can get it compounded so that it's in the proper dose for you, and you don't have to just kind of squeeze out a little pea-sized amount of the male version, which actually doesn't work so bad. Once you get a hang of it, it's pretty easy and it's really affordable to do it that way. But to your point, don't go asking for testosterone for all these like things that we think testosterone is part of. Ask for it for low libido, because that's what we have a global position statement on.
That's right. That's what, thank you for clarifying. I don't want to misspeak. I love that you did that.
But the other important part of testosterone that I see a lot with these women with severe premature surgical menopause, so it's not just libido and desire. There's so many androgen receptors on the vulva, on the clitoris, on the bladder, and on the vaginal vestibule. That's the opening of the vagina. So a lot of these women, even if they're getting estrogen replacement back, because they have such low testosterone levels, and often they're on lowered, women are often not in premature menopause being given, I see a lot of times, sufficient amounts of hormones. They really need full replacement, that they still have a lot of sometimes pain, discomfort, and like lack of sensation. And so I find when we start testosterone on these women, that they're not only do their libido and their desire improve, that's different than actual their sexual response to the quality of orgasms or their ability to be aroused with physical touch, because the androgen receptors in that area, you know, are really important, right? And so when we give back little testosterone there, it improves all of that too. And so let's think about that, right? We're talking about women like in their 30s, their early 40s, you know. And when do we start to see a lot of relationship breakdown, right? And divorces. We see it in the 40s, right? That's when it starts to like, you know, happen. And I'm not blaming all of, you know, that this is causing divorces, but when women have a decade of not sleeping, they don't feel like themselves, their body is changing because no one's addressing this like surgical menopause and no one's prepared them, their sexual response is not going so well. Maybe there's mental health issues happening because of new onset of depression and anxiety from this lack of hormones. So there's a real global impact on every aspect of this woman's life. And you, as a doctor, you have the power to prevent all of that by just giving her evidence-based appropriate medical care. Like this stuff is not rocket science. There's like super clear guidelines on this, but it's, you know, but there's millions of these previvors and these other benign, I say benign, not cancer related early menopause, that are just not getting adequate care.
It makes me sad, but it's what we see every day. And you know what, Corinne, I live in such a bubble now with you. And all of our people who talk about it. I am surprised when I have midlife women come in. I had one last week. She's 46. She had never heard of perimenopause. All these things were happening to her. So finally, it became apparent, and I asked that question. And so I just think the need continues to be so great. And that's why you and I are not going to stop talking at all times about, but I think
it's so motivating, because we hear these stories, because we have a platform where we can hear from a lot of women at once, because people DM us or they comment. Like, it really profoundly has impacted me, because it's not just one or two of my patients that I see during the week, these one or two sad cases. It's literally thousands and thousands of women from now around the world who I hear from, and I know you hear from, and you just sit back and you're just, oh my goodness, I have to make another reel. I have to keep on talking about this. You feel very motivated to do it, right? Because there's so much lack of education. Even I find, Vonda, and I know you've experienced this too, even among circles of people who have access and who should know, it astounds me. I'm like, wait, you have access to these doctors, or you've been talking, or you've been going to these conferences, and you still are being dismissed or not being cared for. It's unbelievable. So I can't even imagine what a woman who doesn't have maybe resources or access to that information, what they're going through.
Well, yeah, I can't believe it's just the void is vast. But this is the perfect segue to you and I were just texting the other day, because what you guys don't know out there is Dr. Corinne Menn is my doctor at MyAlloy.
I was like, what did you just say?
Yeah. Yes, this is my doctor at MyAlloy, which, it's a perfect time, which is a telehealth opportunity for women to reach expert physician care, which, and you head up, you're one of the founding and lead doctors there, where women can have asynchronous conversations like you and I said, hey, I think I can't remember what I was asking for.
Tread to knowing.
Tread to knowing, right? Because you guys treat a lot of things. We were having an asynchronous text conversation about things that I need, but estrogen, progesterone, for the face, I use M4 because I just need this skin to maintain its collagen, right? Vaginal estrogen, all the things. So just when you think there's no hope,
there's hope. There's a lot of places to get care now. And I think it's been really interesting working with Alloy and seeing, because now I have like licenses in, I don't know, like 30 states. And so, it's been over, it's getting close to 3 years now, and it's built over time in the volume. And so because women message, we're messaging back and forth, we do an intake form, we message back and forth. It's really interesting to see what women write, right? So it's different when you have a 10-minute in-person visit with your doctor, and in-person care is really important for lots of reasons. And sometimes, I say, okay, I can take care of you here, but then I want you to go to your doctor, your in-person doctor to get, X, Y, Z. But it's really interesting when women have a little bit of time and space to put their thoughts down. I screenshots, privately, I don't share, but I screenshot them, and I will save some of the things that are written to me so that I remember these stories, because women will write a few paragraphs and say, like, this is why I'm coming to you. I am desperate. I've felt, and they give me the list of symptoms. I've gone to, 4 different doctors. No one will take care of me. Whatever the case may be, they talk about their marriages. They talk about how it's impacting their lives. At work maybe, and it's so moving, and it's from people in cities where supposedly you think you could have access to lots of care, to the middle of Idaho, to somewhere in the deep South where there's not an OBGYN for 65 miles or more, and so it's been really powerful to hear stories from all over the country, right? And it's just interesting when you give people space to actually write what they feel. And there was a paper recently published called NFLM, not feeling like myself. And this statement and its association with perimenopause and menopause. And I can't tell you how many women in their intake form will write, I'm just not feeling like myself.
Yeah.
And my doctor's only solution is to put me on an antidepressant.
Yes. Antidepressant use, to correct this data, but the number that comes to mind is after the WHI came out, antidepressant use as primary care for women in midlife escalated almost on a trajectory like this. I mean, is it 25% higher? Is it 225% higher?
Yeah, I don't know the number off the top of my head. Dr. Heidi Flagg, she's one of our menopause doctor friends from New York City, and she has a beautiful graphic of this, just showing this inverse relationship. And as we see the plummeting use from 2002 to now, and I just actually looked it up yesterday, in 2002, the HRT was about 44% of American women were on hormone therapy.
Yeah.
And over the ensuing years, and very abruptly in the first few years, but it's plummeted to 4 to 6%.
Yeah.
And at the same time as that going down, well, it was certainly around the advent of the SSRIs, but they just exploded for midlife women. And so, now that's often their first option. which, but nobody explains to these women that SSRIs do have an association with bone loss, with low desire, sexual dysfunction, right? Weight gain. So you're taking a woman who is like already dealing with maybe low desire, and she's dealing with menobelly and feeling like, okay, my metabolism's changing, right? And you give her a suboptimal off-label medication for her vasomotor symptoms and insomnia and her bone health, and you do something that is actually not helping much there. I mean, maybe taking some edge off of the hot flashes, and I do prescribe them for women who can't take estrogen, and they can be helpful. I was on it, but it's not the standard of care.
Yeah.
But that's the direction it's gone in.
And it's almost in the women and in my whole person care I'm asking about, it's almost like a reflex.
Oh, yeah.
It's a reflexive move.
Yeah.
Well, I hope in our conversation, people who have been feeling left out, not part of the conversation, which I realize I personally need to do a better job because I'm such a proponent of HRT, and lots of women either don't want to or are never told they can. And so I hope that they're listening today. What a fount of knowledge you are. I wish that we lived closer. I would see you, but I get to see you this summer. So I'm very excited.
Yes. And yes, my husband wants to come and do an executive retreat for all his guys. So you're going to see him soon too.
I would love that.
We'll talk offline about that. Because
all right.
I was so impressed by how when I was at your retreat, how you presented and motivated and like really nourished these women with knowledge. And I said, you and your employees, you need that. I told my
so good. You bring them on. Everybody, Dr. Corinne Menn, go follow her on Instagram. Go hook up with her at MyAlloy. And thank you so much for being here.
Thank you for having me, Vonda.
Thanks for joining us on Hot for Your Health, where we bring you conversations from the bleeding edge of science, health, and culture. You can find links from today's show and connect with me at drvondawright.com. Don't forget to subscribe and leave a review wherever you listen to podcasts. I'm Dr. Vonda Wright. See you next week.